All right. Well, good morning, good afternoon, good evening, everyone. And thank you for joining us for the KAP COVID Dashboard webinar. I'm Susan Cran. I'm the Executive Director of the Johns Hopkins Center for Communication Programs. We're very excited to share the COVID Behaviors Dashboard today, which visualizes vaccine acceptance and prevention behavior in over 100 countries. Today, our experts will share data, insights, and guide users through reading and interpreting the visualizations for public health decision-making. Before I introduce our moderator this morning, I just want to go over 3 quick housekeeping dynamics. First, please note that we'll have simultaneous French translation occurring. I'm going to advance the slides to show our French speakers how to access the interpretation channel. You'll see the name of my colleagues on the webinar today who can help with any technical issues that you might have. Secondly, please use the chat room to greet your colleagues, introduce yourself, and let us know the diverse range of countries represented today. As of yesterday, we had people from over 650 organizations and 115 countries signed up for today's webinar. And lastly, as the presentations occur, please use the Q&A tool at the bottom to submit your questions for the panelists. Some of the questions will be responded to in the Q&A tool. Others will be pushed to the panelists within the open discussion. And now I'd like to welcome our moderator for today's panel, Dr. Jeni Stolow. Dr. Jeni Stolow is a social and behavioral scientist who works at the intersection of medical anthropology, public health, and infectious disease outbreak response. Dr. Stolow is currently responding to the COVID-19 pandemic as the World Health Organization's Global Outbreak Alert and Response Network Research focal point for risk communication and community engagement. Thank you, Jeni, and welcome.
Thank you, Susan. And good morning, good afternoon, and good evening, everyone on this call. We are so happy to have you here to share this wonderful, innovative tool. So as Susan was saying, my name is Jeni Stolow. I will be your moderator for today. I am here representing GOARN-Research. I am very proud and very happy to be here and to be a part of the COVID Behaviors Dashboard initiative that we share with you today. Next slide, please. From the GOARN global perspective, I just wanted to highlight 3 strengths of the dashboard before we jump into our first panelist. So from our global point of view, the first strength of the dashboard is the interactive and nuanced data that we hope will support the ongoing global 19 response. We recognize that data collection and management have been major challenges across this pandemic, so we hope this dashboard can assist in meeting that need. Secondly, we recognize that this second year of the pandemic presents with its own challenges in communication and community engagement, such as a strain on resources, reorganizing of response infrastructure, and what may seem like a plateau in vaccine acceptance and behavior change from our priority populations. We hope this dashboard will serve as a way to provide insights as to how to revamp or revive our COVID-19 communication strategies. And lastly, a major lesson learned from the pandemic thus far has been the need for the interdisciplinary collaboration. This dashboard is evidence of the success that a multi-sectoral collaboration can yield. We're very happy to share all of this with you today. With that, I move to our first speaker, Dominick Shattuck. Dominick Shattuck, PhD, is Director of Monitoring, Evaluation, and Learning for the Breakthrough Action Project at Johns Hopkins Center for Communications Programs. He also co-leads the CAP COVID survey and data utilization efforts in partnership with Facebook, MIT, the World Health Organization, and GORN. Since the COVID-19 pandemic began, his work informs global program implementers and policymakers about risk mitigation behaviors and trends related to vaccine acceptance. Dominick, welcome, over to you.
Thanks so much, Jeni. It's really a pleasure to be here and to be talking about this dashboard after a few months of hard work and collaboration with the partners I'll talk about in a few minutes. And so let's jump right in. So Marcella, if you'd please. The dashboard is an interesting tool that facilitates interacting with data in some pretty cool ways. The motivation for the design is to increase data utilization. It's our goal to put timely and meaningful data in the hands of public health decision makers around the world. Because this is linked to the Center for Communications, we often emphasize countries where there are serious gaps in COVID-related data. And we work hand in hand with global mechanisms to distribute vaccines and vaccine messages. So working closely with them really helps us to kind of keep our focus and to present these data in ways, not just in the dashboard, but in other ways that they can be utilized in the field. If you'll go to the next slide, please. This project reflects a collaboration between the Center for Communications at Johns Hopkins, GOARN, the WHO, which provides oversight and to the data utilization aspects of the project, while the Delphi group at Carnegie Mellon and the Data Sciences group at the University of Maryland both administer the survey and facilitate data access. This work is conducted in collaboration with Facebook and its Data for Good initiative. If we go to the next slide, please. So building on the earlier symptom survey that was implemented by Carnegie Mellon and the University of Maryland, the CTIS integrates additional questions about vaccination and COVID prevention. There are slightly different versions of this survey. In the United States, implemented by Carnegie Mellon, there are a few extra questions that are included around the demographics and things like that, while the University of Maryland and the global survey is a little bit more streamlined and has a few fewer questions than the US-based survey. The dashboard presents data starting from May 20th, 2021, and will continue through the new year. These data could be displayed in a variety of ways. We chose to compile and present these data twice a month. So you'll notice that the data is presented for periods spanning from the 1st of each month through the 15th, and then it's also presented for the 16th through the end of each month. And we did this to kind of compile information and to make the sample sizes a little bit bigger. Okay, so the content is broken into 6 parts. On this slide, you'll see the 4 major sections of the survey: COVID symptoms, testing, vaccine acceptance, and prevention behaviors. Those 4 sections are administered to all the participants. There are 2 additional sections that are randomly administered to half of the participants. We refer to those as modules A and module B. So module A includes questions on beliefs and norms, knowledge and information, and healthcare. Module B includes questions on well-being and parenting behaviors. Due to the randomization, we see some gaps in these data that may reflect as insufficient data on the dashboard. If you go to the next slide, please. So before Toyin and Doug dive a little bit further into the data and the dashboard elements, I wanted to take a moment to discuss the logistics behind this work. The dashboard contains weighted descriptive statistics. The weights adjust the distribution to match the age and gender in each country. We display longitudinal change over time in the dashboard, and you'll notice there will be some gaps in the data, particularly when you get into subgroups. This is because we maintain a minimum of 100 participants per cell size. For example, you can see this in the visualization on healthcare worker vaccination and vaccine acceptance. Only a subset of countries are included because other countries did not have 100 participants that identified as healthcare workers. For those countries, the fields appear as insufficient data. If we go to the next slide, please. I wanted to provide an overview of the recruitment and enrollment process, just to kind of, because I know this comes up a lot in conversation and in the questions that will be in the chat. So just to kind of give a little bit of this up front. Individuals who opt into this study are recruited through advertisements on Facebook. They're then pushed to a remote server managed by Carnegie Mellon or the University of Maryland. Participants are then consented and shown the battery of survey questions. And following a review of the data, Carnegie Mellon and the University of Maryland make those data available through their APIs. No individual level data is shared back with Facebook. All survey responses are self-report, and this includes age, gender, education, location of residence, and other personal characteristics that people are sharing on the survey. Participants can opt out of any questions, and none of the information is exchanged with Facebook in either direction. So there are multiple links within the dashboard that provide additional details on recruitment, the weights that we use to calculate the statistics, and other aspects of the data. Please go to the next slide. So my last slide here is kind of looking forward, even though we're going to have some more information coming up soon. But kind of look forward at that next phase of the dashboard will include some new resources. First, in the coming month, our team will complete and launch a subnational dashboard. This dashboard will present descriptive statistics for the subregions within countries. Second, we realize that it can be useful to have all the data for a given country in a single document. To meet this need, country-specific PDFs will provide a snapshot with a single click. Third, a presentation template will guide users through the development of a slide deck that features the visualizations and interpretations. And last, members of our team are poised to dig a bit deeper into the most salient topics of this rich data set. Soon, additional analyses will be linked to our dashboard and disseminated periodically via social media. Thanks for your attention right now. I'm going to pass it over to Toyin, who will walk you through some of the visualizations.
Thank you so much for that, Dominic. And if we do have any questions about methodology, participants, etc., please do be sure to put that in the Q&A option on your screen. Thank you. Next up, we have Toyin Sang. Toyin Sang is a PhD candidate in the Department of Health, Behavior, and Society at the Johns Hopkins School of Public Health. She has over a decade of experience working on research and interventions, facilitating health behavior change, increasing treatment access, as well as evaluating and promoting health policy and guideline implementation, both in domestic as well as international settings. She serves as an analyst in the development team for the CAP COVID and the COVID Behaviors Dashboard. Toyin, we're very excited to have you. Welcome. Over to you.
Thank you so much, Jeni. It is my pleasure to give an overview of the dashboard. As Dominic mentioned, the COVID Behaviors Dashboard presents data from 115 countries, currently over 12 million data entries from May 20th through August 31st, 2021. Data are pooled for 2 time periods each month. The latest data for September 1st to the 15th will be updated later today. Next slide. There are 15 sections on the dashboard organized into 4 topic areas. These are vaccine, behavior, knowledge and information, and testing. I will give some examples of these different data visualizations. Next slide, please. The first section of the dashboard describes levels of vaccine acceptance among unvaccinated participants in different demographic groups within each country. Participants who indicated that they had not received any doses of COVID-19 vaccination were asked whether they would choose to get vaccinated. The bubbles in this graphic are color-coded for 4 response options, with dark blue representing those who would definitely get vaccinated, light blue for those who would probably get vaccinated, light green, probably not, and orange, definitely not. The size of each bubble is proportional to the percentage of participants who fall into that response category. When hovering over a bubble, a text box will pop up to provide a more detailed description. Here, I'm showing gender breakdown as an example, whereas information about other demographic characteristics is also available on the dashboard. We can see that in Argentina, from August 16th to 31st, the distributions of the 4 response categories are very similar between male and female respondents. However, in Brazil, the different sizes of the dark blue bubbles suggest that more females said they would definitely get vaccinated compared with males. There were also a higher proportion of males who said they would definitely not get vaccinated, as indicated by the orange bubbles. Next slide, please. We can also examine changes over time. On this slide, please notice the icon on the left with an arrow pointing at it. you will see this icon in the upper right corners of the side panels throughout the dashboard. When clicking on it, a line chart will pop up showing data trends over time as displayed here for vaccine hesitancy among unvaccinated participants in Argentina and in Brazil. These are not disaggregated by demographic characteristics. Naturally, we will see this trend increasing. This is because as more and more people get vaccinated over time, those who remain unvaccinated are primarily those who are more resistant to vaccination. Next slide. Unvaccinated participants who did not give a definite yes when asked whether they would choose to get vaccinated were also asked about their reasons for their hesitancy. We can see that in Brazil, the top reasons reported between August 16th and 31st were concerns about vaccine side effects, planning to wait and see if it is safe, and uncertainty about the effectiveness of the vaccine. When clicking on a data point, more detailed demographic breakdown will appear in the side panel. Let's take a look at concerns about vaccine side effects. Next slide. Here we can see that a slightly higher percentage of unvaccinated female participants in Brazil reported concerns about side effects as a reason for their hesitancy, based on surveys collected between August 16th and 31st. There were also slightly higher rates of reporting concerns about side effects in younger age groups and among participants in town, village, or rural areas, and than those living in cities. Although not shown here, data for participants with different education levels are also available on the dashboard. Next slide, please. On this slide is a spider chart showing structural barriers to vaccination experienced by unvaccinated participants who wanted to get a COVID vaccine, meaning those who said they would definitely or probably get vaccinated and actually tried but hadn't succeeded. This graphic is called a spider chart because it looks like a spider's web. Each axis in this graphic represents a different barrier, and the position of the dots along each axis indicates the percentage of participants reporting that barrier, with 0% at the center and the number growing bigger as it gets closer to the outer circle. The dots then get connected into a web. Each layer of the web is marked with a different color based on demographic characteristics. In this case, I'm showing different age groups. Similar to other sections, you can interact with this graphic on the dashboard to view different demographic breakdowns. Here we can see that in Brazil, from August 16th to 31st, more young people said they did not meet the eligibility criteria, whereas other barriers were reported across age groups at more similar rates. Please note that the age group 55 years and older is missing here because during this time period, there were not enough unvaccinated participants in that group who wanted to get vaccinated, but were not able to. Please also note that although we are focusing on the unvaccinated participants here for the purpose of demonstration, users can also interact with the dashboard to select the vaccinated group and view the barriers they experienced when trying to get a COVID vaccine. Next slide, please. Now I'd like to introduce another way of visualizing changes in data over time. In each graphic on the dashboard next to the data collection periods, there is a play button. You can click on the button to start an animation. Please press play. Back in May, most unvaccinated participants in Brazil who wanted to get a vaccine were ineligible across all age groups. As time went by, more and more people became eligible, starting from the older age groups and followed by the younger groups. And as people started becoming eligible, they identified other barriers, such as no appointment available, difficulty traveling to a vaccination site, and difficulty getting time away from work or school. Next slide, please. Moving on to COVID prevention behaviors, participants were asked about their own prevention behaviors and how they think others are doing. The maps are color-coded for different prevention norms and behaviors, with darker shades indicating higher percentages. From August 16th to 31st, 32% of participants in Brazil said when they went out in the public, all or most people maintained a 1 meter distance from others, as indicated by the map on the left. Meanwhile, the map on the right shows that 58% of the participants said that they intentionally avoided contact with others all or most of the time. Next slide, please. This graphic shows the percentage of participants who took part in typical daily activities, such as going to work or school, spending time indoors with others, and using public transit. When hovering over a data bar, the pop-up texts give additional information on the percentage who wore a mask during that activity. From this graphic, we can see that there is an increase in certain activities in Argentina from May to August this year, while other activities remained at the same level. Next slide. The trends within individual behaviors are easier to see when we focus on one activity. On the dashboard, clicking on the names of the activities to deselect them and hide data for those activities. In Argentina, 5% of participants who filled out the survey between May 20th and 31st said they ate or drank at a restaurant in the last 24 hours. That percentage increased to 18% in late August. On the other hand, the percentage reporting wearing a mask while in a restaurant remained similar, around 53 to 54%. Next slide. Participants were asked how much they trust various sources to provide accurate news and information about COVID-19. Between August 16th and 31st, the most trusted information sources in Brazil were scientists and health experts, WHO, and local health workers. Please note that the data label reads CDC/WHO, and I just said WHO. This is because the COVID-19 Trends and Impact Survey has two versions, as Dominick mentioned earlier, one for the US and the other for the rest of the world. The two versions are very similar with slight variations. For this question, participants in the US were asked about their level of trust in CDC, whereas in the rest of the world, people got asked about the WHO. When we hover over the dark blue bar next to local health workers, a text box pops up telling us that in Brazil, 50% of participants reported that they trust local health workers as a source of information. In the side panel, we can see similar rates of reporting trusting local health workers in both genders, with females slightly higher than males. In addition, more young people reported trusting local health workers than people in the older age groups. Next slide, please. Participants were also asked from which of the information sources they had received news and information about COVID-19 in the previous 7 days. This scatter plot allows us to look at the percentage reporting trust in a certain information source and the percentage exposed to that information source at the same time. Data circles toward the right of this graphic indicate high trust, whereas data circles toward the left of the graphic indicate low trust. Similarly, data circles that are close to the top of the graphic indicate high exposure, and those at the bottom of the graphic indicate low exposure. In addition, the data circles are color-coded for different information sources. This current view shows all data circles from countries in the WHO region of the Americas from August 16th to 31st, with circles for Brazil outlined in red. Instead of showing data circles in a particular WHO region, you can also choose to show all data circles for the 115 countries around the world using a drop-down menu on the dashboard. Data from August 16th to 31st in Brazil suggests that scientists and health experts, the WHO, and local health workers all had high percentage of trust for low exposure reported by participants. In contrast, participants had high exposure to journalists for low trust in them. In addition, similar percentages of participants reported trust in and exposure to government health authorities and friends and family. Finally, very few participants considered religious leaders or politicians as trustworthy sources for COVID-19 information. The exposure level was also very low. Looking at other orange and green circles in this graphic, we know that this pattern is similar in other countries in the WHO region of the Americas during that data collection period. Next slide. Finally, in the testing section, I'm using Algeria as an example because it has more participants who reported having had a COVID test in the past 14 days, therefore allowing a more clear view on the breakdown of the test results. We can see that 23% of participants in Algeria who filled out the survey between August 16th and 31st were tested in the previous 14 days. And among them, 47% tested positive and 46% tested negative. When hovering over the purple band, pop-up text suggests that the remaining 7% did not know their test result at the time of the survey. That's all for a brief overview of the dashboard. Thank you, and back to Jeni.
Thank you so much for that. Really great to see really interesting visuals available on the dashboard. Thank you so much, Toyin. We are now about to move on to our last panelist. Please keep those questions coming. Be sure to put them in the Q&A option. All right, next up is Dr. Doug Story. He is a principal investigator for the CAP COVID study. He is a behavioral scientist with nearly 40 years of work in health communication and social and behavior change communication, most of it in international settings. He has lived and worked in 36 countries on a wide range of health and environmental issues, including social and behavior change related to reproductive health and family planning, maternal and child health, child survival, nutrition, malaria prevention, HIV/AIDS prevention, gender, and environmental resource management. Dr. Story has provided behavioral insights to the CAP COVID dashboards. Doug, welcome. Over to you.
Thank you, Jeni, and greetings, everyone. It's an honor to be here with you today. My role in the session today is to talk a little bit about how we might use the data in the dashboard for strategic planning. This is an extremely rich data source, an extremely rich resource for planning purposes. So I can't possibly do it full justice in explaining how you might use this to guide your own strategic thinking for your own country or for your own purposes. So I certainly encourage you to be creative in the way that you use this dashboard, explore it. Take some time to become familiar with the various pieces, the various visualizations available. And know that the data are publicly available. You can request access to the data if you wish to do additional research and analysis of those data yourself in ways that are not specified in the visualizations. What I'm going to do today is focus on 3 breakthrough action countries, Nigeria, Indonesia, and Guatemala, just to provide a few examples of ways we might use these data. I'm going to focus on 4 different applications. The first is identifying a target audience or an intended audience for strategic communication interventions. The second is to think about how to select the intervention channels or sources of information that you might employ to deliver information and engage with your intended audiences. The third is to identify potential mechanisms or levels of change that you might focus on strategically as you allocate resources to improving vaccine acceptance and addressing hesitancy. And the fourth is identifying particular message content that may be of interest to your intended audience. Next slide, please. So some of these visualizations will be familiar to you from the presentation that Toyen just provided. I'm going to start with an example of identifying potential audiences, and I'm using Guatemala in this case. You'll see the bubble graph on the side that provides a breakdown by gender, residence, education, and age in terms of whether people will definitely, probably not, or definitely not get a vaccination. And if you look at the sizes of the bubbles, as Toyen explained in her part of the presentation, we can see that there are some differences, some demographic differences in the level of certainty that people express in terms of getting the vaccine. Now, overall in Guatemala, we see about 73 to 75% total who say they are definitely or probably going to get vaccinated. But these demographic breakdowns indicate that people from rural areas, circled in red here, those with primary school education and those with college education, as well as those in the 35 to 44 year age category, are somewhat less certain. That is, they express less certainty that they will definitely get vaccinated. So this provides a strategic opportunity to think about whether these are appropriate audiences to focus on in order to encourage them to go ahead and get that vaccination. Now, the graph on the right indicates that in Guatemala, vaccine hesitancy has been growing a little bit, has been increasing a bit. And as Toyen said, that will tend to increase over time as people become vaccinated. So this suggests that we may want to think about those who are still hesitant, that have not yet become vaccinated, and consider the concerns of those who are yet to become vaccinated, but say that they have an intention to do so. Next slide, please. Just by way of contrast, if we look at the same kinds of demographic breakdowns for Indonesia and Nigeria, and we scan sort of quickly across the sizes of the bubbles in each of these demographic breakdowns for the 2 countries, we see that there are fewer demographic gaps, both in Indonesia and in Nigeria, across most of these demographic categories. We also find that the hesitancy levels are a little more stable than they were in Guatemala, if we look at that trend line. But what this suggests is the possibility that a more general public communication campaign may be possible in countries like Indonesia and Nigeria, where we find fewer striking demographic differences across age groups, across gender, residence, and levels of education. Next slide, please. A second application of these visualizations of the dashboard may be to guide thinking about intervention channels or the sources that we might want to deploy in reaching people with information. In this case, I'm looking at Nigeria to start with, and we're looking at the bubble graph that shows the levels of exposure to and trust in various sources of information. Again, on this figure, the different colored circles represent different sources of information, and the circles that are highlighted, outlined in red, are those for Nigeria. So as you can see, and I've sort of summarized this in the table to the right, the sources that have the highest level of trust are CDC, WHO, scientists and health experts, local health workers, and to a somewhat lesser extent, government. Again, you can see that politicians tend to fall low on the trust spectrum. But then if we look a little closer at the reach, that is the number of people who report exposure to information through these sources, we see a slightly different picture. CDC and WHO are very high level, have a high level of exposure, as do local government officials, scientists and experts, somewhat lower level of reach, and local health workers somewhere in between. Generally, when we think strategically about the use of channels or sources, we would want to select the channels that are most trusted and those that reach the most people. So we can use this kind of breakdown to think about who might be the most trusted, who we might deploy in order to deliver our information. Now, because we don't have much control over CDC and WHO spokespeople, and perhaps not as much control over scientists and health experts, it's possible that in Nigeria, a good choice for delivering our information would be local health workers or possibly local government. So if we think that these may be important sources based on the level of trust that is engendered by those sources, then we might want to think about ways that we can increase the reach of those sources. Help health workers, for example, to reach more of the population in the communities where they work, or in some cases, perhaps to work on improving the reputation and the trust that government sources of information might have in this particular country. If you, Marcella, if you would click a couple of times on this figure, I've highlighted, again, a few of these. And an interesting thing to note, one more, please. An interesting thing to note, I sometimes find it useful to compare countries in a region that helps to sometimes bring out contrasts and interesting strategic opportunities. And if we compare the position of Kenya government sources to Nigeria government sources, it's interesting to see that both trust and level of exposure to government sources is higher in Kenya than it is in Nigeria. So if you are developing a strategy for Kenya, you might approach this analysis a little bit differently, recognizing that the government sources may be a particularly important source of information to facilitate or to nurture in delivering effective vaccine information. Next slide, please. Here's Nigeria again, and I'm presenting the graph that shows the level of perceived threat or concern over COVID infection. We can use this kind of information to help us identify potential mechanisms of change. What should we communicate to our populations in order to encourage them to consider vaccine acceptance? And if you look at Nigeria, which is about 2/3 down on this list, on the far left, you see Nigeria there. Thank you, Marcella. And we look at the percent who say that they have a great deal or a moderate amount of concern. That's the blue and the orange lines. You can see that there are only 2 other countries in the African region who report lower levels of perceived threat of COVID-19 compared to Nigeria. Yet we know from other data in this dashboard that over 20% of people in Nigeria believe that they have already had COVID-19. So thinking strategically, behavior change theories generally show that perceived threat can motivate protective action. Therefore, what this figure indicates is that perhaps in Nigeria, it would be worthwhile to consider messages about current infection rates to help people correctly understand the risk that they face. It's entirely possible in Nigeria that this threat perception related to COVID-19 is unrealistically low. And if Nigerians are more knowledgeable about the actual infection rates in that country, their perception of the threat may become more accurate and therefore more motivating to consider vaccine acceptance. Next slide, please. Another possible motivator of change or a mechanism of change is through social norms. We know that people who believe, that is, behavioral theories generally tell us that people who believe that other people are practicing a behavior are more likely to practice the behavior themselves. So here is a series of three trend lines that you can view on the norms page by clicking on that icon that provides the trend lines that Toyin described to you. Here are the three trend lines for Guatemala, for Indonesia, and for Nigeria. And we see some different patterns of normative perception here. The purple line in all three of these graphs represents the percentage of people who believe that the majority of others in their community have been vaccinated. And you see that trend line rising for both Guatemala and for Indonesia, but it remains static for Nigeria. That is, the perception of the vaccination norm is low and consistently low in Nigeria. We can also look at some of the other behaviors, such as the normative perception that all or most people wear a mask. That's the blue line. And we see that that's relatively low in Nigeria. We might also look at the actual behavior, the actual reported behavior of wearing a mask all or most of the time. That's the black line. And it's interesting to note that the gap between the normative perception, that is the blue line, and the actual behavior, that is the descriptive norm, the black line, is somewhat wider in Nigeria than in the other two countries. And what this suggests is that there is a gap between the perception of masking behavior and the actual masking behavior in Nigeria. So strategically, what this might mean for the development of a strategy is to think about, first of all, reinforcing norms that are already positive. So in Nigeria, for example, we might continue to encourage people to wear masks because that is already, it appears to be already a majority behavior, and we want to reinforce that. But we also might want to publicize the gap between actual and perceived behavior, particularly in Nigeria, where that gap is somewhat greater. And so if people realize that the actual behavior of masking is greater than they thought it to be, they may be motivated to increase their own masking behavior. Next slide, please. Here's a spider graph. Toyin described how these can be read. Here I'm thinking about other mechanisms of change that may be related to structural and policy barriers as opposed to psychosocial factors like normative perceptions and perceptions of threat. And in these two figures, again, we can look at, in the case of Indonesia, age differences and the barriers that people in different age categories experience. This figure shows that if you look at the yellow dots, shows that younger Indonesians tend to report more difficulty with time and travel constraints compared to other age categories. And on the upper side of the screen, the red and the purple dots indicate that older Indonesians have more difficulty with eligibility and with the difficulty of getting vaccine appointments. Now, we know that in Indonesia early on, there was a priority given to the vaccination of younger Indonesians. And so that might be reflected in this figure where older Indonesians feel that they have that eligibility and vaccine appointments are issues for them. So in a case like this, we might try to think strategically and consider ways that we can address these barriers. Perhaps providing travel subsidies for some audiences might be an option, or creating policies that allow time off from work or creating policies that enable school-based vaccination programs, or perhaps even changing eligibility rules. These might be solutions to addressing these structural and policy barriers. Over on the Guatemala side, we see some interesting differences by education level. Those with a middle level of education, that is the green dots, tend to report more difficulty with eligibility and with difficulties getting appointments for vaccination, while those with higher levels of education, that is the purple dots, tend to report more difficulty getting time off or travel to get those vaccinations, or technology-related issues like technical websites or iPhone difficulties, or inability to document or access internet information. So what this suggests is that for Guatemala, the strategic opportunities may be a little bit different than we see for Indonesia. We might consider changing some eligibility rules, for example, to overcome that barrier, particularly for those with lesser education. We might try to improve online and mobile access to make it more available for those who rely on those resources for information and for making appointments. Next slide, please. Finally, I'd like to talk about one of the visualizations that Toyen did not describe. This is a little bit daunting at first glance to understand what this visualization is showing, but it's actually, in my mind, one of the most interesting of the visualizations. In this kind of graphic, we are providing information about what people consider to be the most important types of information they desire to have. And so within the larger light gray circle, we see smaller circles that reflect the proportion of people who reported each of these major topics. So for example, in Guatemala, in May of 2021, the biggest categories of information that people wanted to know more about were treatment of COVID-19 and different types of vaccines. Coming close behind that were COVID-19, information about COVID-19 variants, and mental health issues related to isolation and social disruption associated with COVID-19. If we fast forward to the data from August, we see that this interest in particular kinds of information has shifted a little bit. And while treatment of COVID-19 is still a major source, a major interest for people in Guatemala, we see that information about the COVID-19 variants has grown in importance, as has an interest in information about mental health. So this suggests that there may be some, by tracking the way that these information needs are changing over time, we may be able to zero in on the types of messaging content that we may provide in our public communication efforts. So in this case, we might consider increasing the focus of messages on risks of new variants. We might consider increasing messaging about maintaining mental health under stress. And we might continue to provide updates on the scientific evidence related to how to treat COVID symptoms effectively. One more slide, please, Marcela. In comparison, here is a snapshot of the informational topics that people from Indonesia most want to have. And this comes from the August data. And you can see that compared to Guatemala, the information that people most want to have is how to deal with economic impact and employment issues. These were not as important to audiences in Guatemala. There's also a relatively higher interest in Indonesia on how to maintain social relationships in the midst of the lockdown and the social disruption that COVID has caused. So again, this suggests some potential strategic directions for us. We might consider in Indonesia increasing message content to emphasize some of the government response to economic hardship, some of the social safety net programs that the Indonesian government has created. And we might think about messaging that provides suggestions about alternative ways to stay in touch with family and friends and deal with the disruption of the normal social relationships that COVID has brought. So I hope this is helpful in beginning to think about ways that you might strategically use the dashboard data. I want to emphasize that the dashboard cannot answer all of the questions that you might have. I think it can help us to identify some important issues to investigate and may suggest some important strategic directions. But we should all think about other sources of data that we have available to us in country and the local wisdom that exists in country that can help us to elaborate on these findings and perhaps fill in gaps in what the data dashboard is able to provide. So thank you very much. I appreciate your time, and I will look forward to any questions that you have.
Thank you so much for that, Doug. I love how you're bringing the data alive by showing how we can connect to behavior change theory, how we can translate data into policy change or communication efforts. So thank you so much for that. We are now going to dive into the question and answer portion of the webinar, so keep those questions coming. But I do want to kick off, Dominick, let's start with you. There are a couple of questions about, isn't qualitative data best for behavior studies? Where is the qualitative data in this dashboard? I'll pause there.
Yeah, this is a large global survey, as you're learning. If you haven't already engaged with this project in the past, there is not an opportunity to capture that qualitative data. And oftentimes, as Doug was mentioning a few minutes ago, these data should be triangulated with other data that are locally collected and maybe capture some of that contextualization and nuance in the data set and in that community of interest. So unfortunately, this project doesn't have qualitative data digging in further, but it's definitely the next step. And we understand that, we hope that the dashboard and the data behind it will provide that first step toward defining the goals and the objectives of that contextualization and qualitative research that you're going to implement when you build messages and when you test your messages. And so we're really hopeful that we can kind of move that process along for you with this dashboard and the data behind it. And then you can build it out and validate some of your theories and approaches on the ground.
Great, thank you for that. And following up, there are a lot of questions about methodology, representativeness, accessing the data, et cetera. Is there an FAQ page or somewhere that our audience can be directed to for answering those questions?
Absolutely. There's an FAQ page on the website. There's a drop down at the very top that'll get you to the FAQ. In there, you'll find more information about the methodology and the process. There's also more of that in the methods section, and it tells you how, it gives you links to the survey itself, but also tells you how we have filtered the data step by step, and so that you can understand better what is being presented to you in this dashboard. We've tried to take as transparent an approach as possible, and if there are questions, we are really happy to respond to them. And you can even, in that FAQ section, I think there is actually a request for some feedback in there as well as some other points in the dashboard.
Great. And one more question for you, and then I'll let you off the hook.
Yeah.
There is a lot of interest for these upcoming subnational PDFs, zooming into more contextual situations. Do you know when those will be available or where people can go to sign up for alerts and information about that? Yeah,
so first the alert, so the sign up. So please go to the bottom of the dashboard itself. There is an email sign up. Put your email into that box, and we will have you, and you'll receive some of the periodic updates and of the different materials and resources that we're pulling together. The PDFs, we have had conversations every day this week, and we'll continue until we get those completed. We're hopeful that by the end of the month, we will have those to share out. It may be an evolutionary process where we kind of have an initial PDF that summarizes things, and then we add to that a second or a third page so that you have a really concise snapshot of where your country is at this point in time. I'm really excited that people are actually interested in this. This was something that Jeni and I had actually talked about a long time ago. And it really, I think it speaks to the value of kind of having a concise picture of what your country's got going on at that moment. And again, to take it to the next step in country and to validate those findings locally.
Great, thank you so much. I'll let you get back to answering some questions in the chat. Toy-Yan, I want to move over to you. Thank you so much for all of those visuals and walking us through all of the capabilities of this wonderful new dashboard. I'm curious, are there any interpretation assisting options on the dashboard? There are a lot of visuals, and we're getting a lot of questions about insight tools or some way that users can be supported in understanding the data. So can you speak to that a little bit?
Yeah, thank you, Jeni. That's a great question. So on the dashboard, under each section, under the section headline, there's a brief introduction of the section. On the right-hand side, in the same text line with the title of the section, you will see an icon that looks like a magnifying glass. This is called an insight icon. And if you click on it, there will be more information, including a more detailed description of the graphic, public health significance, how to interact with the graphic, and additional information. And I would really encourage everyone to explore those information on the dashboard.
Great, thank you so much. And I imagine that's also a part of the FAQ page that we would love all of the members of the audience to review. All right, Doug, you're going to take us home. I just want to give you another opportunity to highlight what you mentioned at the very end about how this is meant to supplement data or support other types of in-country data. Can you talk a bit more about this idea of triangulation and taking different data sources to make sense of our COVID response? Thank you.
Sure, thank you. We've acknowledged that this data set does have some limitations. It collects data only from people who have access to social media, and that obviously does not include everyone in the population of an entire country. We take some pains to weight the data a bit to make them more representative of a national profile in terms of age and gender, for example. But there are going to be gaps, and so it is important for people to use other data sources that are available in your country or other data sets that are available internationally to fill in some of those gaps. And I'm thinking of surveillance data, for example. Many countries have available public data from health facilities that can provide more information about service utilization and about the populations that are served by different kinds of health services or health resources like vaccination. We have a lot of information from many countries have a lot of information from other national surveys that are conducted around this. Those would tend to be more periodic or more far spaced than the data that are available here. But they may contain much more detail about some of the dynamics of behaviors that we're interested in and may provide more insight into particular subgroups that we're not able to identify specifically in this data set due to our limitations of the instrument and so on. So I would strongly encourage you to use these data to provide some indications of where you might go with further analysis. And for those of you who are really research oriented, I think these data also suggest some important opportunities for additional research that may shed light on aspects of this phenomenon of vaccine acceptance that we're not able to detail in this survey, even though it has an enormous sample size and is highly detailed in many ways. There are just certain things, certain questions that it does not answer. So I would strongly encourage you to think about the kinds of research that might be indicated by these data. And I'm responding, if I can take just one more minute, One of the questions in the Q&A from Shaun Lahiri was about how do you, he was responding to some of my comments about normative influences. And he said, how do you identify normative reference groups? And this would be a really interesting topic for further research in your particular setting. I would refer you to Dr. Holly Shakya at, I believe, the University of San Diego, University of California at San Diego, who's done a lot of work on this issue of normative reference groups, including developing tools for identifying the reference groups that people use in different aspects of their personal life as sort of touch points or as sources of social information and social influence. And so I would refer you to some of this other research that is available that we might want to build on in fleshing out some of the gaps that admittedly exist in these data from the dashboard. Thank you.
Great. Thank you so much. And thank you everyone for your participation, your questions. Be sure to stay tuned. You will be getting an email following up on all of this. And we really encourage you, check out the dashboard, connect with us. We love getting feedback. It's been an absolute pleasure to chat with everyone today. If you have any questions you want to reach out, please feel free to do so. I thank the panelists one more time. We are so happy to be here. So great to chat with y'all. Have a great day, everyone.